Hi, everyone. Welcome. Hopefully you can hear me. My name is Monica Feeks. I'm the Director of Development for Scripps MD Anderson Cancer Center. We're so happy to have you here. I want to just thank all of you on behalf of Scripps Health Foundation for joining us today. We have a very special program for you, so cross your fingers that all our technology works as we planned it to. Obviously, we wish we could be doing this in person, but I just have a couple of housekeeping announcements for you. If you could go ahead and mute yourself if you haven't been muted already, and if you could also turn off your video, you'll have the ability to see we'd love to see you all, but you'll have the ability to see our speakers today. So if you turn your video off, you can see all our speakers during the program, right? I want to thank everyone who submitted questions in advance. We have lots of questions to answer, which is wonderful. And our speakers are going to do the best they can to get to every single question. I want to also say that we are going to send out a post-event survey to you tomorrow. And I want to encourage you to fill that out because that always helps us do better as we do these events and learn what things work and what things don't. But that's enough from me. You don't need to hear from me anymore. I want to introduce you to our special guest who's going to lead our program this evening. Dr. Buck Holtz is our medical director of the Scripps MD Anderson Cancer Center program, and he's here with us with some of his colleagues who I'll let him introduce. We're so thrilled that he is leading the charge with cancer care in San Diego at Scripps. And prior to joining us in 2018, he spent over 20 years at MD Anderson in Houston. So who better to be leading the charge? So Dr. Buck Holtz, I'll let you take it away and introduce the rest of our panel today.
You did something. What did you do now?
Thanks so much, Monica, and thank you all. It's thrilling to see so many people engaged in this. Of course, it's Breast Cancer Awareness Month, but we're so appreciative of coming together as a community to hear about some of the really exciting advances that are happening right before our eyes and happening at Scripps MD Anderson Cancer Center. We're going to have an opportunity to talk to 4 of my colleagues in the multidisciplinary of breast cancer, someone from diagnostic imaging, someone from surgery. Just a reminder, if everybody looks up in the top right corner, there's a little microphone. And you can click on that microphone and it'll put a line through it. That's how you mute yourself. That will prohibit a lot of background noise for our speakers to be heard clearly. So thank you very much for following that instruction. Just one other housekeeping item. If anybody has to use the restroom, it's right up this door and to the right. This is all about the virtual world we now live in. But I've been a breast cancer doctor for over 25 years now, and I could say what an exciting disease progression course we've made over that tenure. Probably the most exciting news that I want to bring forward today that I hope you're aware of is that breast cancer death rates continue to decrease in the United States. Again, they went down. Every year since 2002, the death rate from breast cancer has gone down. And in part, it's attributable to great work in early diagnosis, great work in more effective surgery, great work in new therapeutics that Dr. Ali could talk to you about, both in hormonal therapy and chemotherapy, great works in advances in radiation technique that Dr. Lynn's going to be able to share with you, and great works in surgery. Dr. Rivera are going to be able to comment on some of these things. But despite all these advances, breast cancer still remains a serious problem. It's estimated that there are going to be over 275,000 new cases of breast cancer this year. That's a really dramatic number. And unfortunately, despite all of our improvements, there's still over 40,000 women who are going to die of breast cancer. So that's unacceptable. And that's what motivates the doctors that you'll hear on this panel every day. That's what keeps us going to make cancer history, to continue to make new advances. So in addition to the standard of care, you might hear about some new and exciting protocols we have going on in our conjunction in collaboration with Scripps MD Anderson today. We hope that we want disease of breast cancer to be diagnosed early. It's estimated now if you present with localized breast cancer, do you know what your outcome is? You have a 5-year chance of survival of nearly 99%. And even if it involves the lymph nodes, when I started in my career as a breast cancer doctor, at that time it was a coin toss, about a 50-50 chance. But the most recent data for lymph node positive breast cancer nationally is a 5-year survival of 86%. So you could see dramatic improvements. So breast cancer is no longer something that you have to die with. Now you have to live with it. And so we've also created advances to help with breast cancer survivorship. We're doing things differently surgically to give better longstanding quality of life for the many decades to come. And same with radiation and same with chemotherapy. Some questions had come up about what are risk factors for breast cancer? Well, unfortunately, the two biggest risk factors are female sex and increasing age. And those, of course, aren't things that we can modify, nor do we want to modify. Clearly, family history is important, density of breast tissue, use of estrogen replacement therapy after menopause has been so associated with breast cancer development risk and is no longer recommended as a component of care. But things that one can modify themselves, alcohol intake is probably one of the most nutritional aspects. I don't know if you call alcohol nutritional, but things that we take in ourselves. And modifying the alcohol intake can reduce your risk of breast cancer. Exercise and lack of obesity, minimize the fats in the diet. Those are all important things that you could do to help minimize your risk of breast cancer moving forward. And then there are also some types of chemopreventive people or treatments for people who are at high risk. So even hormonal therapies that are used for the treatment of breast cancer can also be preventative in breast cancer. But one of the most important things to do with breast cancer to get a good outcome is early diagnosis. And with that, I'd like to introduce my first guest, Dr. Simferosa Williams. Dr. Williams came to us following getting her medical degree at Yale Medical School. You may have heard of that school. It's a small university on the East Coast that would never accept me into their undergraduate or medical class. Subsequently, she did her training with the United States Navy and was here at the Navy Medical Center. And then in 2002, joined Scripps Clinic Medical Group. She's recognized as one of San Diego's top doctors and really specializes in breast imaging and diagnosis of breast cancer. So welcome, Dr. Williams. I think if you don't mind, can you talk to us a little bit of some of the advances in screening for breast cancer and also what your recommendation would be about when to start screening and how often do you have to have screening? Dr. Williams.
Thank you very much. It's such a pleasure to be here, and thank you everybody for joining us. My current practice is mainly as a breast radiologist, about 70-80% purely breast imaging and about 20 to 30% oncology and cancer imaging. A lot more time for administrative duties, but that's pretty much my focus is breast imaging. As far as screening techniques, I'm going to apologize, first of all, for using women because we all know men get breast cancer, but for surveillance, men fall into a slightly different group. So I'm really targeting more towards our screening population. Basically, what we recommend and what everybody on this panel believes in is annual screening mammography as the first step to detect breast cancer. We recommend starting at 40 years old for the average woman, and that would include especially women of color, since women of color tend to get breast cancer at an earlier age, a more aggressive form, and or may have a diagnosis later for many reasons with a poorer prognosis. We recommend that you continue screening annually until a decided upon age, which I'll touch on a bit later. There's a little bit of a controversy with the primary care physicians, who some of which may say get an exam every 2 years. That is based on some studies that the radiology and surgery breast care line think were flawed. So our national organizations continue to say to try to screen every year. And what I tell patients is that even if your primary care provider says go every 2 years, you can certainly request to be sent in every year, which is what we recommend. And insurance usually will cover annual mammograms. The other thing I also tell patients is that even if your insurance refuses to pay any more than every 2 years, self-paying for a mammogram every other year is less than we spend on a good bag or shoes or massage or hair appointment, and it goes on and on. And a mammogram could save your life. It's really important. There's no official age to actually stop screening, unlike the European countries. Our recommendation is that a woman continue screening mammography as long as she has 7 to 10 years of healthy life ahead of her, and if she is willing to accept further management if cancer is diagnosed. I had a lovely patient I diagnosed 10 years ago at the age of 80, and I really had to cajole her into letting me do her biopsy. This year, unknowingly, I met her family and became friends with some of them, and I had the pleasure of seeing her at 90 years old, feisty, beautiful, and absolutely grateful that she didn't give up 10 years ago. So it's a very subjective decision that we ask you to make in conjunction with your family and your primary care doctors. So mammograms, what is the latest standard for screening? I would say 3D or tumor mammography is the latest standard for screening and preferred in most women. And it is probably especially important if your breast tissue is described in your mammogram report as being dense. Doesn't mean that the older 2D machines are obsolete. They're still functional, they work, we can still read mammograms, but 3D does give us more ability to detect subtle abnormalities. If you examine your breast as an orange that you've skinned and you're trying to count the seeds inside and you just squish it flat and try to guess, you're not going to see many of the seeds. If you slice the same orange and look at the slices, you're going to get a relatively accurate count of how many seeds are in that orange. That's the difference between 2D. 2D gives us the squished breast image, and 3D gives us slices through that squished breast image. So we're just able to see a lot better. So it definitely is preferred. And I'm very proud and happy to say that most of our machines through our Scripps have been upgraded to 3D technology. We still have a few sites that do need upgrading, and honestly, any help in that regard is always appreciated. I'm really not too proud to beg. We want to keep providing the best care to our community.
Well, thank you. Dr. Williams, can people request 3D mammography from their primary care doctor, or say they get their healthcare outside of Scripps? How would they know if they're getting a 2D or 3D mammography?
I would say the most important place to start is with your primary care doctor. They need to order a 3D mammogram, because if you come in with an order for a 2D mammogram, there are some facilities that won't change it. It's a little bit of a difficult thing to do on the fly. But if you ask your doctor for a 3D mammogram order to start with, and then you go to a facility that has 3D mammography, you will get that done. As far as knowing whether it's 2D or 3D, you're not going to know just looking at a machine, but definitely ask whether the facility has 3D or not, if that's what you desire.
Great. And we wanted to get to know the panelists a little bit. Can you tell us something fun about yourself before you became an Ivy Leaguer?
Oh, wow. Gosh, well, I was actually born in New York. My dad was at Columbia doing his doctorate. Our family is originally from Ghana. And so we went back to Ghana when I was 3, and I grew up in Ghana and returned to the US when I was 20. And I kind of came on my own with a broken suitcase, $80 in my pocket, didn't have anywhere to live, but was convinced that I was going to get back into school because I was actually in medical school in Ghana. So long story short, I figured things out, got back into college, got into Yale. That's why I fell in love with radiology. It really is a modality where you're putting clues together and coming up with solutions to puzzles. And while doing that, I also realized that I wanted to maintain patient contact. I wanted to take care of people and not just be the typical radiologist like a bat hiding in a cave. So I gravitated towards breast imaging because I have some risk factors myself. And this gives me patient contact. I feel like I am part of the actual care team, and that I really do make a difference in their lives.
Well,
so
thank you.
That's my story.
Such a pleasure to have you as our colleague at Scripps MD Anderson and have your leadership.
Thank you.
We're going to turn now to Dr. Lou Rivera. Dr. Rivera did his medical training at the University of Pittsburgh. He went on to do his surgical residency. This is where, like, you watch the television shows and, you know, they're on call all the time doing trauma. This is surgical residency. He did it at Navy. And then following, when you get to be a board certified surgeon, then you're about 30 years old at that point in time, and most people want to go out into practice, but he was so dedicated to oncology, he went into what's called a surgical oncology fellowship, which entails 3 extra years of subspecialty training just in surgery. And he did that at Roswell Park Cancer Center in New York. He's been an active duty member of our United States Navy up until recently when he joined the Scripps MD Anderson community here this year. Dr. Rivera, it's a pleasure to welcome you to this audience as a new member of Scripps MD Anderson. Can you talk about how you approach the workup and discuss surgical options for people with early stage breast cancer, and what are some of the outcomes? Can you also mention for people who might want to undergo genetic testing, what are some of the considerations concerning that? So Dr. Rivera, welcome.
Well, thanks. I really appreciate the opportunity to be part of this group and to share my thoughts. I think regarding how I interact with patients, I think I'm privileged to be in the position often to meet patients as the first person they encounter when they're exploring their options for care. And it provides me with a unique opportunity to explore patients' needs without any preconception. And I like the idea of having the opportunity to figure out what the patient's initial concerns are and figure out how not just my efforts, but the efforts of the team will play a role in achieving their goals. I think the first objective I set for myself in terms of evaluating a patient is to determine the appropriate sequence of therapy. It's very natural for a patient when they see me, and often they're seeing me as the first part of the treatment team, to think that surgery needs to be done immediately and surgery is the preeminent part of treatment. But that, unfortunately, is not always the case, especially for individuals who have special types of breast cancer. For most patients with early stage breast cancer, surgical treatment is sort of the foundation or maybe the initial step in treatment. But there are some individuals who present with tumor features like having a receptor status that would mandate consideration of other treatments as being critical to achieving a good outcome in terms of survival. An example would be a person who has a cancer whose cells express a receptor called HER2. Now, these individuals, depending on the tumor size, may benefit from a sequence of therapy that's non-traditional, where surgery isn't the upfront approach to care. There are patients who may present with early stage breast cancer and still have what's called triple negative breast cancer. And consideration should be given to treating these patients not with surgery first, but potentially with other therapies, drug therapies as the initial part of their treatment. And so I have an opportunity to go over these concerns with the patient and determine, first of all, what the appropriate sequence of therapy is. Now, for most people, their options for therapy are broad in terms of surgery, radiation, and potentially drug therapy. But for most patients, over 75% of patients who present with breast cancer present with early stage breast cancer, stage 1 or 2. And surgery initially figures prominently for those patients. So the next thing I like to consider is whether a patient is a candidate for breast conservation, which I think is preferred, versus mastectomy, which is definitely indicated for patients who have maybe a larger volume of disease or maybe some aesthetic concerns that won't play in their favor for breast conservation. But I think that's the next critical step. I am a pretty strong advocate of breast conservation. I think women who have the option to pursue breast conservation fundamentally have the same outcome from their treatment versus women who pursue mastectomy. The survival is no different, and breast conservation offers an opportunity for an individual to potentially maintain the integrity of their breast. Breast conservation therapy seems to be associated with higher quality of life outcomes that women will have to address in the kind of survivorship period of their care. And as survivorship advances and mortality from breast cancer decreases, I think survivorship issues need to come to the fore. I think those are the two things I consider when I'm initially evaluating a patient. And then regarding genetic screening, when I approach a patient initially, I do a pretty thorough review of their family history, in addition to some other risk factors that I use to predict an individual's future or an individual's risk of harboring a genetic mutation. The particular model for prediction that I use is one of several that are available and advocated by the National Comprehensive Cancer Network. But what I'll do is I'll look at several features, including a woman's initiation of menarche, or when a woman starts having menstrual cycles. I'll look at their age of menopause, their age of onset of their first pregnancy, and then other factors figure prominently in how to predict a risk of potentially carrying a genetic mutation. For instance, most notably a family history. So I'll go over a family history very thoroughly and generate a pedigree for the patient. And I'll use all this information, and with the model that I use to predict their risk of harboring a genetic mutation, I'll be able to tell them what their potential risk for genetic mutation is. If their lifetime risk of harboring, say, a BRCA genetic mutation is over 5%, that would automatically trigger a referral to a genetic counselor, and that patient would benefit from genetic counseling. For individuals who have breast cancer and a family history with one or more relatives who have breast cancer, they should be considered for genetic testing. For women under the age of 45, because this is considered an early age of onset, women under the age of 45 would benefit from genetic testing. Women with triple negative breast cancer, so their tumor cells don't harbor the estrogen receptor, progesterone receptor, or the HER2 receptor, if they're under the age of 60, they also would benefit from genetic testing. And the guidelines that I use to determine selection for genetic testing are from the National Comprehensive Cancer Network, and I utilize those to determine patients' potential benefit from genetic testing above that 5% threshold, or in addition to that 5% threshold on algorithms. And then I'll make an appropriate referral to genetic counseling.
Thank you, Dr. Rivera. One of the really great points that you hit on highlight kind of why working at MD Anderson is such a joy. You know, with support from our donor community, we've been able to bring in a number of genetic counselors who work side by side with the doctors. Another important aspect that you mentioned about the importance of sequencing, chemotherapy, anti-HER2 therapy, surgery, radiation, all points out that each case is somewhat unique and really requires integration of disciplines. And another benefit for patients is they could be seen with a new cancer diagnosis in what we call a multidisciplinary conference. And a multidisciplinary conference or clinic could actually see 3 doctors in a single appointment, where they could see a medical oncologist, a surgical oncologist, a radiation oncologist, and also have our genetic counselors right down the hallway for us and give a real comprehensive team-based approach. Every case that requires multimodality, or the majority of cases anyway, are presented in a multidisciplinary treatment planning conference. So you get an immediate second opinions from all the other members of the community too. And oftentimes we share some more challenging cases with our colleagues back in Houston. But outstanding presentation, Dr. Rivera. Thank you. We're going to move to Dr. Sonia Ali. Dr. Ali specializes in medical oncology. She's a breast cancer medical oncologist. So medical oncology is responsible for giving treatments that treat the whole system, or systemic treatments, and she could allude to you the various types of systemic treatments that are effective against breast cancer. She comes to us, oh, before we forgot your fun fact, Dr. Rivera. Tell us how you got interested in becoming a cancer doctor.
When I started medical school, I was dead set on being a family practice doctor. And in my late third year, I had everything set up to become a great family practice doctor. And then I got assigned the surgical oncology rotation, and my life changed. Unfortunately, at that time, I became a cancer survivor as well. And I was able to receive a lot of mentorship and support, both as an individual and in my professional development. And I think the composite effort of the people that that kind of nurtured my career path at that time, and that exposure really kind of really helped me hone in on my focus to become a surgical oncologist. And that never varied after my fourth year of medical school. And that happened at I was at the University of Pittsburgh at the time. And the opportunity also afforded me to meet my wife and to start a family. So that's how I started on that path.
That's a good survivorship story. Well, thank you. Thanks for sharing that. And now to Dr. Ali. I've asked Dr. Ali, who actually did her oncology training at perhaps the best oncology program where you could get trained, that being Scripps Clinic Medical Group and Scripps Oncology Fellowship Program. And so she was trained at the best and stayed on then, and has now been an important attending or faculty position. As I mentioned, a close colleague of all of ours who specializes in systemic treatments. She, in addition to giving some thoughts about advances in the number of systemic treatments for breast cancer, I asked her to mention a little bit about inflammatory breast cancer. She helped start California's first inflammatory breast cancer clinic here. We were the first to start it at Scripps MD Anderson in the entire state of California. And she now leads our effort as part of a nationwide effort based out of the MD Anderson network. So Dr. Ali, welcome.
Thank you so much for that introduction. So I wanted to touch on some trends in medical oncology. And I thought I'd start by telling you that, in about a few decades ago, the trend was more therapy, multiple treatments for longer durations. And now we've been working really, really hard to de-escalate therapy and make sure we're not over-treating patients. We're also tailoring treatments to specifically target high risk and treatment refractory patients. And Dr. Rivera alluded to that earlier, where if you have certain subtypes of breast cancer, instead of moving with surgery first, we actually use some of our systemic therapies first, so we can see in real time how the patient is responding to the treatment. We may be able to convert someone who, because of tumor size, was not able to have a partial mastectomy. They would have required a full mastectomy. If we're able to shrink the tumor before surgery, we may be able to convert them into a lumpectomy candidate. So part of the advances in medical oncology have been using treatment up front and determining the response to that treatment to tailor treatments after surgery. Sometimes we do an amazing job and we're able to kill off all the cancer cells before the patient even gets to surgery. So the surgeon targets the area that was marked with a biopsy clip, they go in, cut the area out, and there's no more cancer cells there. We're able to use that information to provide them with a better prognostic outcome. We're able to tell them you have a better prognosis. But that doesn't always happen. And so in patients in whom they receive treatment before surgery, they have residual disease, well, then we've been able to identify them as such and offer them more treatment. So not just telling everyone that they need a wide variety of treatments, but we're able to now target our treatments more specifically to the patients who need it most. In terms of inflammatory breast cancer, this is a subtype of breast cancer. It's rare, it's aggressive, and it accounts for less than 2% of invasive breast cancers diagnosed in the United States. Typically, patients will present with rapid onset redness of the breast, including swelling, maybe some warmth, pain, and it may or may not be associated with an underlying mass. When I said rapidly, I meant that this usually happens over the time frame of weeks to months, but typically not more than 6 months. The skin can take on a thickened appearance, and we liken it to an orange peel, and we call it Podorage, which is skin of the orange in French. And the reason that it takes on this appearance is because characteristically in inflammatory breast cancer, cancer cells will invade the channels, the lymphatic channels that are present in the skin. They block off those lymphatic channels, causing backup and buildup of fluid, giving this swollen appearance. So, unfortunately, many patients are treated with antibiotics first because it's thought to be an infection. And a lot of patients and primary caregivers aren't aware of this diagnosis because it's so uncommon. So they're treated for infection, it doesn't work, and then the diagnostics continue until ultimately they are diagnosed with this entity. If you have a diagnosis of inflammatory breast cancer, multimodality therapy is really, really important. Typically, patients will start with chemotherapy, then move on to surgery, and then radiation. One of the goals of the merger with MD Anderson in Houston was to allow patients outside of Houston access to clinical trials here in San Diego. And today I'm really proud to report that we officially opened a new clinical trial for advanced or metastatic inflammatory breast cancer patients. This is using an oral agent called Rabastanib. It's combined with chemotherapy, and preliminary anti-tumor activity was seen in a phase 1 trial. And so we're going to continue to look at the anti-tumor activity. So I'm really happy that our IBC patients now have access to this trial, not only in Houston, but here in their backyard on the West Coast.
That's fantastic. Congratulations, Dr. Ali. And we're helping kind of the traffic patterns, because whereas previously so many San Diegans would have to travel up to Los Angeles or other places to gain access to subspecialized medical care, I think Dr. Ali and I have seen a number of people from Sacramento, from San Francisco, from Los Angeles, all coming down now to Scripps MD Anderson to gain access to this specialized clinic and her expertise, and now have the availability. It's an inflammatory breast cancer specific clinical trial on the West Coast, I would argue. So fantastic. And finally, I'm going to ask my colleague and friend, Dr. Ray Lin. Dr. Lin is the leader of our radiation oncology group. As I mentioned, I myself am a radiation oncologist. So whenever I'm not there in clinic doing administrative duties and my patients see Dr. Lin, they immediately say, "My gosh, he's the best doctor ever." And in fact, whenever I travel around the city of San Diego and get introduced, everybody says, "Do you know Dr. Lin? He took care of so-and-so," because I think he's the consummate great cancer doctor. He did his medical school in Chicago after undergraduate at UCLA. He did his residency at Loma Linda and has been a longtime member of our Scripps community. He's going to talk to you today about some of the advances in radiation treatments of breast cancer. So Ray, thanks for joining us and welcome. And you're on mute, Ray. Thanks.
There we go. All right. First of all, thank you for the nice introduction, Dr. Buckles. I also want to congratulate all the patients on the phone who are breast cancer survivors. Thank you so much for letting us be a part of your lives all of these years. And thank you so much for letting us care for you. I see these names popping up in the lobby, and some of you have become my extended family over the years. And I just really want to congratulate you and thank you for that. You know, I went into breast cancer care for a couple of reasons. Number one is high curability. And number two is high treatability. Even the ones that cannot be cured these days can live years and years and years. As Dr. Buckles said, the 5-year survival now is over 95% for all of these patients and all of these women. You know, so high curability and high treatability. And I'll tell you a quick story. Several months ago, I saw a patient that I treated 15 years ago. She had stage 4 breast cancer 15 years ago. She said, Dr. Lynn, you told me I had stage 4 cancer that was not curable 15 years ago. So I sold my house, I quit my job, and I traveled the world. Thanks to you, I'm dead broke. That's what she said. So, I mean, she said it tongue in cheek. She gave me a hug. She thanked us for taking care of her all of these years. But that is the why I went into breast cancer treatments. I know I'm going to answer your question, Dr. Buchholz, but I also wanted to say that, you know, I'm so happy that we're part of Scripps MD Anderson now. I'm so happy that we partner with MD Anderson the last couple of years. I can tell you, I thought we did a great job taking care of breast cancer patients for the last 20 years that I've been here. But I have to say that the Scripps MD Anderson program has really impacted our program in 5 different ways. Before we started working with MD Anderson, I didn't realize this, but talking to other cancer doctors from Encinitas to Scripps Mercy to Scripps Chula Vista, I realized we all treated a little differently depending on where we were trained and what equipment we had. So before we started Scripps MD Anderson, we all got together and decided to come out with common practices. We're all going to treat stage 1 this way, all going to treat stage 2 this way, stage 3 this way, and stage 4 that way. Then before we started number 2, we met with MD Anderson doctors and came up with a program so that we're consistent with MD Anderson. We wrote this big manual, Scripps MD Anderson Breast Program. And Dr. Ali was on the committee, and we spent a year writing this manual. Number 3 is we have access now to world-class MD Anderson doctors. Okay, they're world-class lecturers and world-class doctors, but they're also world-class people. Anytime I call whoever on the phone, they answer right away. And it's great because sometimes we get rare diseases and rare cases, and just to pick your brain really gives us a lot of confidence that we're doing things right. Number 4 is the research program that Dr. Ali touched upon. We're also opening a clinical trial in radiation oncology. And number 5, the multidisciplinary clinics. Before we joined MD Anderson, when a patient had breast cancer, they see Dr. Ali across the street on Tuesday at Green, myself on Wednesday here at Torrey Pines, maybe Thursday, Dr. Rivera down at Mercy or wherever. Now you have one appointment, you see all 3 doctors at once, we do one exam, and we present you to a committee composed of social workers, doctors, radiologists like Dr. Williams, pathologists, geneticists. So anyways, I want to touch upon that. Now, getting to the advancements in breast cancer treatment and radiation oncology, the exciting things are, number 1 is we used to treat breast cancer 6 to 7 weeks of treatment in radiation therapy. So my patients who were treated over 5 years ago, they came in for 6 weeks. Now we know you could do just as great of a job in 3 to 4 weeks because the research has shown that you can give a little higher dose and do it a little bit quicker and you get the same results. As a matter of fact, I think you get less sunburn, less effects, but you get the same results overall in terms of survival. So number 1, quicker treatments. Number 2, better technology. And it's thanks to our Scripps MD Anderson donors that we were able to get better equipment. So thank you all here for all your donations because we've been able to do a better job. If you can show the first slide, I will show you. One way to treat patients is now on your stomach. If we're treating left breast cancer patients, you know, when you treat breast cancer, we worry about the heart. But if we treat you on your stomach, what happens is that breast hangs toward the floor. Okay, so it's away from the heart. And we can angle the beam, first slide, away from the heart and treat, that's not the slide, but that's okay. We can treat the breast with the breast hanging away from the away from the board. Another thing that we have done is we can do what's called deep inspiration breath hold. Before your chest moves up and down with breathing, right? So before, what would happen is if we treated the left breast, sometimes a little bit of the heart would be in the field. Although the incidence of heart disease was less than 1%, we wanted to do better. So now what happens is when you take a deep breath and you inhale, what happens is when you inhale, your ribs moves away from your heart. So we can program the beam to turn on and off based on your breathing. So when you take a deep breath, and your chest moves away from the heart, the beam goes on. When you exhale and the beam goes off. And we have this technology because of our wonderful donors. The third thing is we're looking at partial breast radiation therapy. Instead of treating the whole breast, these days we have programs where we treat, so that's a picture of treating the breast. See, before, when you don't have that breathing, a little bit of the heart is clipped. Now with the breathing, you take a deep breath, the heart is awake. So that's that picture of what's called deep inspiration breath hold. You want to show the next slide real quick? The next slide is lying on your stomach. You can see the breast now hangs away from the heart. So you're treating less of the heart and less of the lungs. So what I was saying is now a new clinical trial is treating partial breast radiation. Instead of treating the whole breast, we're just treating the partial breast. We know that 40 years ago, all women had to have mastectomies, but there were 6 major international trials that randomized women into lumpectomy with radiation therapy versus mastectomy. And all 6 international trials showed equivalent cure. So we know that lumpectomy with radiation therapy, you don't have to have a mastectomy, results in an equivalent survival. Now we're trying to find out whether we really have to do the whole breast. Maybe we could treat the partial breast, and maybe we can go from 4 weeks to 1 week. So we have an exciting clinical trial open along with MD Anderson that treats just the lumpectomy cavity in 1 week. And this is based on a European trial called the Fast Forward trial, where women were treated with 1 week of radiation therapy to the lumpectomy cavity, and they had very, very good results. So we're very excited to open what's called the Opal 2 trial in conjunction with MD Anderson here right in San Diego.
Yeah, we hope that's going to be able to really define a new standard of care for women nationally. It's a practice-changing clinical study that we're going to be doing in conjunction with our colleagues, and it's brother and Dr. Lynn's going to be our principal investigator, and thank you for that effort. I wanted to take some time now. We have just about 15 minutes, and a lot of people have submitted questions, and I might, as the moderator, choose to call on some of my colleagues and perhaps Dr. Ali and Dr. Lynn. There's been an interest in male breast cancer. Clearly, we know that men can get breast cancer. It's much less common than getting it in women. Sonia or Dr. Ali, is the fact that someone's male, does that lead you to treat differently with chemotherapy or hormonal therapy, or how do you approach that? And similarly to you, Dr. Lynn, is radiation indicated for male breast cancer? So we'll start with Dr. Ali. I think you're muted. Thanks.
I've actually never done that before. So male breast cancer is actually treated very similarly to female breast cancer. Patients should be offered the option of mastectomy or lumpectomy with radiation. And when it comes to systemic therapies, we're using the same drugs and we're using the actual tumor to guide treatments, not the sex of the patient. One difference is that when it comes to hormone blocking medications, we're going to tend to use tamoxifen more than aromatase inhibitors in a male patient. If you do use an aromatase inhibitor, which is a type of hormone blocking pill, then you have to use an additional treatment, which is an injection once a month. So to avoid that, you'll find that most hormone sensitive male breast cancer patients will be on tamoxifen. The other important feature of male breast cancer is that that is one of the reasons to be referred to a genetic counselor. If you yourself have male breast cancer or a family member of yours was diagnosed with male breast cancer, you need to meet with a genetics counselor. And now you're on mute, Dr. Buchholz.
You got me. Dr. Lynn, do you want to make some comments about how you approach male breast cancer from radiation?
Sure. So male breast cancer is very rare. The most common, there's a few risk factors for male breast cancer. Number one is the BRCA2 gene. Number two is male breast cancer is usually in older men, at least over 60 years of age, what they call older. Number 3 is previous exposure to estrogen for whatever reason, or prior radiation therapy, or a history of testicular inflammation. These are risks for male breast cancer. But in male breast cancer, in terms of radiation therapy, the treatment is the same. However, most oftentimes males do choose to have a mastectomy, because if they don't have much to begin with in their breast, a lot of them do choose to have a mastectomy. If they choose to have a mastectomy, sometimes they do not need radiation therapy. But for those who have a lumpectomy or those who have mastectomies, and there are many lymph nodes involved, we do treat with radiation therapy very similar to how we treat women.
And Dr. Williams, obviously imaging must be different in male breast cancer. Do you sometimes use ultrasound, or do you do mammograms, or what would, if someone was diagnosed with a mass in the breast that was suspicious, what are the types of imaging for such an individual?
Actually, for males with masses in their breasts, imaging is actually very similar. And I frequently will joke with them that now they understand what their wives go through every year. They will start with a mammogram, and if it's a lump, we will go to ultrasound, whether you're male or female. The only times you don't go to ultrasound in a man is if it's gynecomastia, which is just the female tissue behind the nipple. But if it's anything other than that, yes, we'll go to ultrasound as well. And after diagnosis, we certainly have quite a few male patients who come in for annual mammograms after diagnosis and treatment. So it's very similar in that way.
Thank you. Dr. Rivera, I saved you for a different question. I was going to see if you could comment about this entity called DCIS. What is that? Is that cancer? Is this precancer? How would you treat that entity? Does that require surgery?
So DCIS is cancer. It's the earliest stage of breast cancer. It's typically treated with surgery because it represents the early stage. Often, when additional treatments are required, it's for sort of as insurance against recurrence. But the fundamental treatment for this type of breast cancer, and it is indeed breast cancer, is surgical therapy. And the goal is complete removal of the tumor with a relatively wide margin of normal tissue around it. The current guidelines suggest that at least 2 millimeters of clearance of normal tissue around the area involved is associated with the best outcome. When patients opt for breast conservation, they often will benefit from additional therapies to lower their risk of the cancer coming back in that breast. And that would be radiation therapy and potentially anti-hormone therapy with Drs. Lin and Dr. Ali.
Thank you.
I would like to add, it's a common question in our clinic, we never use chemotherapy for a diagnosis of DCIS.
Yeah, so DCIS is ductal carcinoma in situ. In situ is kind of, doctors like to speak in Latin sometimes. It makes them sound intelligent. But in situ means contained within. So while Dr. Rivera says is cancer, if you look at an individual cell under the microscope, it appears to be a malignant cell. But if you look at inside the architecture of the breast, the good news is it hasn't invaded. It has started in the milk duct and it hasn't invaded into the breast tissue. And so it doesn't have access to the lymph channels that could lead to spread to the lymph node, and it doesn't have access to the circulatory system that could cause a metastasis. And that's why the focus is really in removal and prevention of recurrence such that it doesn't develop into an invasive breast cancer. So, and Ray, sometimes
Yes.
you use radiation, sometimes you don't. I guess, how do you do that?
That's a perfect question. So I was going to say that one of the advancements in radiation oncology is also knowing when not to treat. I think knowing when not to treat is really, really important when we, in cancer care. And with DCIS these days, we have molecular markers we can test on the tumor to see what your risk of recurrence is with or without radiation. Because not everybody needs radiation therapy. If it's a non-aggressive, low-grade tumor that's very small with wide margin in an older woman, sometimes that pre-cancer or pre-DCIS will never turn into an invasive cancer in your lifetime. And it may not be a threatening cancer. So some patients we do treat with radiation to try to prevent a recurrence for both DCIS and invasive cancer, and some patients we don't.
I know we have, particularly you mentioned molecular testing of cancer cells and gave an example. I know, Dr. Ali, sometimes you use different genomic profiles to help decide if we should use chemotherapy or not. And even when cancer has spread to other sites of the body, when it's stage 4 or metastatic breast cancer, sometimes you could do complete genomic profiling of the tumor and looking at not just a couple genes like estrogen and HER2, but looking at a vast array, looking for mutations. Can you describe kind of how you use genomic medicine to guide your treatments?
Sure, that's a great question. So these tests are available to be performed on tumor tissue, but we now have the ability to do this from a blood draw. And the information we're able to attain tells us the mutational overlay or the underlying blueprint of the tumor itself. And we can use those characteristics to guide our treatment. We know that certain mutations, for example, in hormone-sensitive HER2-negative breast cancer, will be refractory or non-responsive to various therapies. And so we know to avoid those treatments by using these tests to tell us about the mutation present in a patient's tumor. Another way that we use these tests is we have treatments that target specific mutations. And if you have breast cancer and it harbors a mutation for which there is a treatment that targets that mutation, but we don't usually use that treatment in breast cancer because this mutation is something that's present in lung cancer. So for lung cancer patients with that mutation, they have a targeted treatment. Well, now here you are sharing that same mutation. Well, what if we use that treatment that we typically use for lung cancer in your situation because you have breast cancer, but this underlying mutation that's similar? Will that work? So we sometimes look at the profile of the tumor to guide these treatment decisions, especially when we are at a crossroads in terms of limited options. And so we're looking for some other novel type of treatment and really targeting it to a mutation that's harbored within the tumor. Another comment I'd like to make about that is that tumors change over time. And so we tend to like to do that sort of testing when we're going to use the information and it'll have some impact on next line treatment. Because a tumor that in stage 4 disease will have different markers at the onset as compared to 3 or 4 lines of treatment later.
Dr. Ali, it's remarkable if you think just even this year about there are new drugs available that weren't available last year, right? It's incredible. And the pace of change of how we are approaching kind of advanced stage breast cancer and our what this understanding of the genomics of the tumor is leading to new therapies. There's a big advance called Herceptin against this HER2 drug that really gave a terrible outcome and made it now into a good outcome because it's so sensitive. But now, how many anti-HER2 drugs are there? I can't even. Oh my gosh, there are so many. And what I like to say is the FDA worked very efficiently to work from home. We got so many drug approvals after the pandemic. It was incredible. And one of my favorite drugs to use is something called an antibody drug conjugate. And I call this the Trojan horse of chemotherapy. It's basically where you have a chemotherapeutic that latches onto a receptor, and then once the cell internalizes that treatment, it releases its chemotherapeutic agent. So it's really dramatically reduced toxicity from treatment.
And this year alone, we had 2 new approvals for antibody drug conjugates, one in HER2-positive breast cancer and another in triple-negative breast cancer. So that was really exciting from a medical oncology standpoint.
And equally exciting, Dr. Rivera and Dr. Lin, I know lymphedema or chronic arm swelling used to be not an uncommon consequence of local regional treatments of breast cancer. But Dr. Rivera, now there's this newer technique called Sentinel lymph node surgery, which we haven't mentioned yet. Can you just describe what that is?
Sure. So sentinel lymph node biopsy is a way to minimize the impact of staging of breast cancer. So for invasive breast cancers, it's important to know whether that tumor has learned the trick to spread into a patient's system. And one of the best ways to do that, the best test to do that, is to sample lymph nodes. And that gives us a high degree of confidence in determining whether that cancer has learned the trick to spread beyond the breast. The sentinel lymph node biopsy takes advantage of the fact that these lymph vessels that are present in all of our tissues drain to one specific area in the majority of patients. And really all we have to do is figure out where they drain to and harvest those 1 or 2 or 3 lymph nodes that the breast tissue drains to, and that will give us a very high degree of accuracy in determining whether the cancer has spread to those lymph nodes. And the way we do that is a radioactive liquid is administered underneath the nipple of the breast. And then in the operating room, we can use a very sensitive, essentially, Geiger counter to detect where that radiation is and selectively remove those lymph nodes. The risk of lymphedema or arm dysfunction associated with that procedure is in the 5 to 10% range, whereas historically, when a procedure was done to remove all of those lymph nodes, the risk of lymphedema approached or exceeded 25%. So that has been a very critical advancement in the surgical approach to the staging component of therapy.
Well, I can't thank all of the panelists today enough for all you do, obviously on this panel to help us gain education of the advances in, but more importantly, for being such outstanding colleagues and the care that you deliver every day at Scripps MD Anderson for our breast cancer community. We're so fortunate to have such talent here within our community that provide not just compassionate care, but care that's at the forefront, the expertise that you provide. And I know each of you, how dedicated you are to helping those in need. And I want to thank you too, as Dr. Lin said, when you talk about breast cancer and making a difference in breast cancer, it requires an entire community. And we live in a great community. San Diego has been so supportive and giving back to our breast cancer team and enabling things like genetic counselors through your philanthropic support, enabling some of the newer technologies. We want you to be engaged. We want you to be every bit a part of our team. And please too, support us with your efforts, your thoughts, your philanthropic gifts. I'm sure Monica and the team from our foundation would be happy to circle back with any of you. If you have communities that you'd like us to come out and meet with, if you have opportunities that you think of people who you know that want to give back to breast cancer, either through research or through program support, we can't do this alone. You know, the cost of doing these clinical trials that Dr. Ali mentioned, that Dr. Lin mentioned, requires real dollars. The cost of providing outstanding multidisciplinary care really requires your support as well. So we thank you for joining today. Monica, are you all set? Do you have any last closing moments? Or
I just want to say thank you so much, Dr. Buchholz, Dr. Lin, Dr. Ali, Dr. Williams, and Dr. Rivera, so much for your time. I don't know, I can speak on behalf of the audience. We could have listened to you all speak for probably another hour. It was fascinating. Thank you to everyone who joined us today. My name is Monica Feeks. I'm the Director of Development for the Scripps Health Foundation. So of course, if you have any questions about how you can support these fantastic doctors, we'd be happy to talk with you, as Dr. Buchholz mentioned. Thank you so much. Have a wonderful, happy Halloween, and thank you for joining us.